Dokie. Good morning, everybody. Coming in here a little bit early before this week's office hours. And let's see if I can change the share. Come back over here. Zoom. All right, there we go. Yeah, let's just see how this is going. Good morning. All right, so we're just going to see who pops in here. We had quite a few people say that they wanted to join the conversation this morning, so that's pretty exciting for me. I do really enjoy having an opportunity to speak directly with more of the community members. So today, I'm just going to go over a few things. I'm going to welcome a lot of our new community members to the FlightCrit community, and I want to answer some questions that I've gotten in the past couple of weeks about flight and critical care transport. As many of you know, I collect questions when people join the group, and so a lot of the questions that I've been getting have been really excellent. So I like to take these questions and reach back out to the community and give you guys an opportunity to follow up and ask more questions. Hopefully the audio is okay. Using my microphone now, and I just want to make sure that it's not too loud. So if you want to leave me a comment here in the comment section, you can do that. Just let me know if it's too loud or if it sounds good. And we'll kind of really get things rocking and rolling here in the next few minutes. I'm going to give people an opportunity to come in and listen in. Let's see. So I have this pulled up right now. I can see some people watching. You can leave comments below. Matt, thanks for joining the broadcast. That's cool to see you here. And if you want to share this out, get more people here in the broadcast, that'd be excellent. If you have questions that you want answered, you can definitely do that as well. So let's see here. You just kind of see me plugging around over here, just taking care of some administrative stuff, and then we'll get going. All right. So let me spool. I'm going to just be scrolling here. If you see me looking down, it's just because I'm looking at my notes that I've kind of taken and just kind of finding out what we want to talk about this week. If you're new, I want to welcome you to the group. We had, we broke the 4,000 mark this week, which has been super cool for me. I never imagined that FlightCrit would get this big, and we get some really great conversations in here. So if you are new to the group, welcome, and thank you very much for joining. Pretty excited about that. What else do I want to talk about? If you are new to the group, and this is the first place that you've found me on Facebook, my name is Sean. I host the Tips from Crit podcast, which has been kind of on hold for a while for a number of reasons. Primarily is I also run the website FlightCrit.com and the FlightCrit Academy, and I've been in the process of developing a flight paramedic, critical care paramedic, flight nurse review course for the last several years. And that's where the majority of my effort has been focused right now. So when that is all done, I will be taking a lot of the content and rolling that back into the podcast. So hopefully that's a real benefit to you and the community. If you have questions that you would like featured on a podcast in the future, there is a website that you can go to. where you can leave me a question. You can leave me a voicemail directly from your phone. It's or your computer. It's askflightcrit.com. And that will drive you directly to a site where you can send me an audio question. If you look at episode 6 of the Tips from Crit podcast, you will be able to. How do I turn that off? Sorry, you might get some notifications pop up on your screen that I just can't control because they're through Facebook. You can send me a voicemail. If you listen to episode 6 of the Tips from Crit podcast, you can kind of see the format where I had a community member call in, ask about reading 12 lead EKGs. I like to feature those recordings in the podcast and then answer the question. So it's kind of a really fun, dynamic way to engage with you, the listeners. You can become part of the show. And I feel like it's a good way to include you, because really Tips from Crit and FlightCrit, it's all about serving the community members and basically getting to the heart of the problems that you have with your education and your role as a critical care provider, and kind of answering those questions and really helping serve you and get you through those roadblocks that you may be experiencing, whether that be getting into a new job, preparing for your exam, preparing for a interview, or just simply improving your clinical practice. And that's what this is all about. If you've listened to let's see here. If you've listened to the broadcast last week or any of the replays, I went over a number of different topics like vet management, hemodynamics, a little bit with balloon pumps. And so you can definitely go back, scroll through the Facebook group and find those recordings. What else are we going to talk about today? So let me scroll through some of these questions that I've gotten recently. So CVP monitoring and waveforms, ABGs and lab values. This community member is coming to FlightCrit from a 911 system. It doesn't sound like he's flying just yet, getting ready to take his test very soon. So these are topics, this is kind of how it comes in. And so these are topics that I would address will address on the show. Let me see what else we have here. All right, I'm gonna go ahead and pause this for just a minute, let some more people come in, and then we'll be back in just 1 second. Okay, so here we go. Let's see. Like I said, looking through some more of these questions. So here's a question that I want to answer from one of the community members who asks, when starting a flight job, did you take time off or did you continue to work your second job? That's a really good question. And so I have my opinion on that is, of course, it's really going to depend, right? If you're getting started, a lot of programs are hiring full-time staff out of their PRN staff. I know that where I'm working right now, that's what they do. And so with that, right, it's not probably not going to be an option for you not to work a second job. If you are new to flight or critical care, the learning curve is really steep at times, and it's a big transition. And so what I tell people is do everything you can to minimize your, sorry about that. That blue light is like blaring, isn't it? To minimize your obligations so that you can focus on, there we go, that should be better. So that you can focus on what you have to learn. Things, you're going to be going through some sort of an academy, most likely. You're going to be going through, of course, your orientation manual. So in addition to just getting acclimated to the flight environment and working around the aircraft, working with new partners, you are going to be doing clinical rotations, most likely through ICUs if you are working for a hospital-based system or any kind of quality system. They're going to have you rotate through various clinicals within a healthcare system, whether it be the one that you're affiliated with, or if you're flying with a private program or a non-hospital based program, they'll have some kind of a partnership with a hospital. So the learning curve is very steep. There's a lot of information that you're going to need to gather or assimilate in a short period of time. And so I always say it's best to minimize your obligations so that you can just focus on your time. Now, of course, if you're a PRN staff or part-timer, you still need that primary job, then of course your efforts have to be put to supporting your family and supporting yourself, and so that's when you may have to double up. But as much as you can minimize the additional requirements on your time, it's going to serve you well. So if you're an instructor, don't teach classes, try to make sure you have childcare lined up, so that you're not having to figure that out throughout the process. If whatever it may be, just try to minimize those requirements, have everything set up and lined up ahead of time so that you're not having to worry about scheduling and time commitments other places. So I'm going to try and answer this question here. Let's see. I got a really great question from a flight nurse. But I don't. Well, I'm going to put this one out to the group. This is one that I'm not familiar with. This new member asks, I don't understand AV/APS mode on our transport BiPAP. This is not a mode that I'm familiar with, so I just looked it up. This is called average volume assured pressure support. And this is for non-invasive ventilation. I don't know what ventilator this individual is using, but I'm going to actually post a link to a PDF document that's put out by Philips Respironics, speaking about this AV/APS guide, the right pressure at the right time for more patients, comfort, more efficiency. This is an interesting mode. It sounds like support function can be activated. I'm not going to get in reading this, but I'm going to post this for you to read it. If anybody has experience with this mode of ventilation and you want to comment, put your comments below or put a post in the in the comment section on Facebook, and hopefully I will reach out to this individual who posted this question and have them look this up. I'm not familiar with this mode of non-invasive ventilation, but I'm sure that there's some people out there that are. I'm going to have to look this up. See, this is one of the great things about about this group is that, I'm learning just as much as you are about this world that we work in, from questions just like this. So AV, what is this? AVAPS, average ventilation, assured pressure. Is that what I said? Average volume, assured pressure, support. So it sounds like this is going to make sure that the patient is getting the set pressures, and is going to target some kind of a volume. So I suspect maybe this is almost like a PRVC mode for invasive ventilation, where you're going to set the volume that you want, and it's going to deliver that at a safe pressure. Average volume, assured pressure. So it's probably the opposite of that, because we're pressure ventilating them with BiPAP. They're going to get this set pressure, and it's going to average out the volume, so you don't run the risk of volume trauma. Say their lung compliance improves, at that same pressure, you could potentially overventilate the lungs and induce some kind of volume trauma. But good question. Definitely interested in checking that one out. Who else is watching here? So I can see that there's a couple people viewing the live broadcast. If you guys want to leave a quick comment in the comment section. Let me know who you are and where you're watching from, and that way I just know who's checking us out. I do like to be able to address you by name and say hello. Ventilators. So here's another question that I recently got from a very recent community member on ventilators. If you have not been paying attention to the group, I posted a fantastic article by the guys over at Rebel EM, and I will go ahead and post this here directly in the broadcast as well. But they have a series of posts out called Simplifying Mechanical Ventilation, part 1 through 5. And I highly recommend you read this article if you have any questions about mechanical ventilation. I will post a link to part 1, which is also in the group. And at 10 o'clock today, there will be a link going out for part 2. But if you read the post and then go to the bottom, you'll see links to the other parts of this blog post. But this is fantastic from the guys over at Rebel EM. Who's the author? I forgot his name. So this is written by Dr. Frank Lodeserto. I do apologize, Dr. Lodeserto, for saying your name incorrectly. But this is also peer reviewed by Dr. Salim. Gosh, I wish I could say your last name. I've been trying to figure this out for a long time. Maybe you can correct me, but Rizir, man, I'm terrible with names, but anyway, I did see that Dr. Salim, we'll just leave it at that, had some interest in checking out this podcast or this broadcast. So if he happens to pop in, that would be awesome. Doc, if you want to just say hello, leave a comment in the comment section and let us know you're here. And maybe, down the road, we can actually set up a conversation for the podcast or, for the broadcast, which would be fantastic as well. But anyway, so Simplifying Mechanical Ventilation, this series I will direct you to for any questions about mechanical ventilation to get you started. And then what I would say is follow up with me in the comment section, or you can send me a message over at FlightCrit.com and I will follow up with you and answer any specific questions. There's so much about mechanical ventilation that if I were to go into mechanical ventilation right here, it would take up 3 hours of your time. And that's all we'd get to. So I'll direct you over here to this series. It's fantastic. We'll leave it at that for right now. Let's see. Here's a good question. So, always looking for tips and tricks involving sedation strategies for the typical hypotensive. Is there ever a typical patient? A typical hypotensive, poorly sedated, intubated patient. Had a few of these lately. Now, I would agree. I've had a few in the last several years that I struggled with. Remember, if you're bringing a patient out of an emergency room or you're working with your nurse partner, intubated patients are often going to be on propofol coming out of an ER or an ICU. Because it's a good drug that allows for rapid titration, both up and down, especially if a patient needs a sedation vacation to check neurologic status, etc. And it can also be slowly, gently weaned down so that they can encourage the patient to wake up, especially when they're getting close to extubating somebody. Here's my experience with propofol in the transport environment. We're taking somebody out of an ER or ICU that's typically fairly low stim, meaning they're not being stimulated a lot. And we're now putting them into a transport environment where there's a lot of stimulation. Okay. My experience has been that propofol is ineffective at maintaining adequate sedation, especially in already hemodynamically compromised patients. And so what I find is that they wake up because the sedation is ineffective. And now you're fighting this patient who's, reaching for their tube, or, they're spiking their ICP, they're gagging on the tube. And so more and more it's becoming acceptable to use things like ketamine. Okay. Now, I know we've all been hearing about ketamine, forever, and it's I think we're all kind of tired of hearing about ketamine. But the truth is that a ketamine sedation, a ketamine infusion, can be a really valuable option in the transport environment. We know that it's relatively hemodynamically stable. Okay, meaning it doesn't directly affect your blood pressure. It causes amnesia. Well, not amnesia. It's a disassociation. So the patient has no real care about the situation that they're in. It's a very potent analgesic, so it's taking care of any pain that they might be in. And it's a good sedative. And it's a great sedative. Typically, your infusion is going to be in that realm of 1 mic per kilo per hour. Okay, that's a relatively typical infusion rate for ketamine. And what I've found is this does a really good job keeping them adequately sedated without dumping their blood pressure. Now, if you don't have ketamine infusions as your option, then you're probably better off just going with a fentanyl Versed, okay, because it's very titratable. And it doesn't seem to be as have such a hemodynamic effect as propofol in those doses that we would need for transport. It's not uncommon to dose somebody that 50 to 100 mics of fentanyl and 1 to 2.5 milligrams of Versed, as needed. Now, remember, there's definitely been a push in the post-intubation sedation world of discussion about making sure that you are adequately providing analgesics, and then follow that up with your sedation. The researchers are finding that there's much better long-term outcomes in the ICU when a patient receives a lot of analgesics And when I say a lot, I mean, not snowing them to the point of, they're unconscious, but you do want to keep them well sedated so that their pain or give them plenty of analgesics so that they're comfortable. When somebody's comfortable, they're not really so concerned about, what you're doing with them, and then giving them just a little bit of analgesics just to kind of take the edge off and keep them nicely sedated and comfortable. So that would be my recommendation there. If you're dealing with a patient who's hypotensive, and you're having a difficult time keeping them sedated, because that's where the question was directed, is these hypotensive, poorly sedated, intubated patients. What are your strategies? Strategies are figure out, why are they hypotensive? Are they hypotensive because they've received too many narcotics or benzos? Are they hypotensive because they have cardiogenic shock and they need support? Are they hypotensive because they're bleeding? Correct those problems first, and then address your sedation, and hit them with analgesics first, get them comfortable, especially those analgesics that are going to be less hemodynamically compromising, so like fentanyl, or if you have ketamine. Ketamine is a great alternative to propofol, definitely, or morphine, right? So that's what I would say about that. Study tips and test taking tips. This is from a paramedic who's getting ready to become a flight paramedic. Here's what I found about studying. Okay, the best thing that you can do for studying, and the literature supports this, is there are all these mental tricks that you can do in order to improve your studying. First of all, making sure that you have the right resources. There's a gazillion books out there that you can grab. I mean, I could show you my library. There's a whole bunch of books out there that you could use. There's a lot of opinions about which texts are best and which texts to go with. Here's what I would say is that ask around, find a good textbook, one or two good textbooks. If what you're trying to accomplish is just simply improve your clinical skills, then get yourself a comprehensive textbook. This is the one that I use. It's the Critical Care Transport text from the American Academy of Osteopathic. What is this? It's AAOS. American Association of Osteopathic, I don't know, I can't even remember. But it's supported by the American College of Emergency Physicians. I have no sponsorship or affiliation with the AAOS or Jones and Bartlett. I did receive this textbook for free to review, and when I am all done with it, I will be passing it on to a member of the community. But I do not receive, just in full disclosure, I do not receive any kind of financial support for any of the material that I receive. The only time I ever recommend anything is if I have adequately reviewed it and feel that it is a value to the community. So just putting that out there. But this is the one that I use. I believe it's comprehensive enough for clinical practice. Now, if what you're really trying to accomplish is you're already an accomplished provider, and you're just simply trying to prepare for the exam, then there are other resources out there that will target the exam that are of great value, and I can share some of those as well. The Back to Basics by Renee Halloran, not Renee Halloran, Lopez, Renee Lopez. Fantastic book. The Will Wingfield ACE Prep book is also another really good one for getting you used to the type of questions that you'll see on the exam. Those are probably two of my favorites. There are a bunch of other ones out there. But anyways, as far as test taking tips go, or studying tips go, find a couple books, and then don't get yourself too wrapped up in bouncing from textbook to textbook. The material, if you've gotten yourself a good textbook, it will be solid, and you can use that to help your studying. Secondly, set up a routine regimen. Okay, you want to be studying on a regular basis. at a regular time and in a consistent place. Okay, there's a lot of psychologists. There's a lot of research in the cognitive psychology world that talks about routine, and that goes down, as far as studying in the same place. You put yourself in a place, your brain recognizes, okay, this is the time to study. And that's going to help with your studying. Develop a study plan. The last thing you want to do is wait till a couple weeks before your exam and then just start cramming, because you're just not going to retain the information. Most people who really want to excel in the exam and want to do more than just simply pass the test will take a year or more to really study thoroughly for these exams. Now, there are people out there that will tell you that they took a review class, a 2-day review class, and at the end they were offered the exam, they tested, they passed, and that's all they care about. If that's what you want to do, great. But I feel we have an obligation to be solid providers, and these review tests or these professional certification exams are meant to test our knowledge and our ability to function as a provider. So if all we're doing is preparing to take the exam, cramming, and when it's all over, you don't remember half of what you learned, well, then you're not really doing yourself any good. You're not doing your patients any good. So take time, create a schedule that you can follow for an extended period of time, break the exams down into topics, and then study a little bit at a time. Take naps. Okay, your brain, it's called consolidation. Okay, when you learn something new, it goes into the short-term memory portion of your brain, and when you rest, your brain takes that information and it assimilates it, it consolidates it down into your long-term memory. Okay. Now, some will say, you only retain like 20% of what you study at any one time. So by chunking, that's another term that you'll hear in the cognitive psychology world, is chunking your studying into, rather than, 1 8-hour block of time, you do, a 30-minute block and take a break, another 30 minutes, take a break. What you learn and what you retain the most is what you studied at the beginning of that block and at the end of that block of time. Okay. And so by creating smaller chunks, you essentially have more beginnings and more ends. And so the information that you're likely to retain, there's more opportunity for you to retain that information. So, what is it called? There's a tool. My goodness. There is a tool on my phone that I use to help with studying. Why am I drawing a blank on this? I'll think about it while we're working here, and I will then post it. But it's an app that I use to remind me to get up and take breaks, and not only short breaks but long breaks. What is that called? It's really useful. I'm going to find this because I really want to share it with the group here, because I think it's or anybody who is studying for the exam, and is looking for something that might help them with their studying, because I have found that using this process helps tremendously with my retention. Okay. And that's what it's all about, right? Is the retention. Bear with me for just a few minutes. If you have questions that you want me to address specifically, you can put them in the Thank you, William. American Academy of Osteopathic Surgeons. Good grief, I have no idea why I totally blanked on that one, but thank you for posting that. If you guys have questions that you want me to address, just go ahead and put them in the comment section, and I will do what I can. I'm just pulling up this. I'm actually pulling up iTunes because I want to find this app for you guys. Sorry, it kind of slipped my mind what it's called, but I will find it. And while this is pulling up, I will we'll continue. So let's see here. What else? How can flight medicine impact the growth of mobile integrated healthcare? By mobile integrated healthcare, are you thinking more about like the community paramedic service? And if that's what you're talking about, how would flight medicine integrate or impact the mobile integrated healthcare? I'm not really sure flight medicine will, honestly. I think my opinion, and this is just my opinion, I feel like with these community outreach services, these are definitely more along the lines of preventative care and keeping people out of emergency rooms unnecessarily. So I feel like they're a completely separate beast here, that the mobile integrated healthcare system and the acute care are completely separate and independent of each other. That's just really my opinion. I don't really think that there's going to be a big impact. Perhaps in some other countries where you have like villages, like in the Australian outback, where they have villages that are quite remote. They may utilize flight medicine in order to bring people into the healthcare system. But I think here in the US, I just don't see that it having a big impact. Here in Colorado where I work, there was an attempt at bringing mobile CT scanners to patients with stroke symptoms, and actually getting these TPA resources on board the patients sooner. And I think that really has not panned out to be an effective approach to stroke management. I feel like I haven't heard a whole lot about it, but it was kind of all the buzz initially, and then very quickly, I feel like it kind of died out as these agencies that were trying this started to realize that the cost to benefit ratio was just not sufficient enough, and then you still need to get a patient to definitive care, for neuro ICU care after they receive some of these thrombolytic therapies. So I just don't feel like flight medicine is going to have too big of an impact on this mobile integrated healthcare system. Let's see here. Rafael Horta, thank you for everything you're doing. Hey, thanks, Rafael. I appreciate that. Yeah, it's fun. I enjoy doing this. And the more I get people like yourself in these office hour broadcasts, asking questions and engaging, the more fun it is for me. And I feel like, that's really why I started this, is to reach out to more people in the community and be able to answer your questions and provide a service in a way that's accessible. The great thing about Facebook is everybody's got it on their phone. And so, I can do these broadcasts and still reach, people that aren't necessarily sitting in front of your computer. If you're sitting in your ambulance and, you're sitting on a street corner, you can still have access to this style of education. I will, a little update here. I am in the process of searching for a physician advisor for a training group that we will be putting together. And with that training group, I'll be able to issue already approved continuing education hours. Now, the hours that I issue for the EPICC Review Course can be used for your FPC renewal, but they do not satisfy the required 16-hour review course because the review course is yet to be approved. Now, I am working with a physician, and hopefully we'll be getting that approval here sooner rather than later. And when that happens, then those hours will work to satisfy the review course, the 16-hour required review course hours for renewal of your FPC. All right. Well, I'm not going to spend any more time looking for this app, but I will share it to the group. And so when you see that pop up, if you were listening here, you'll know what that's all about. It is an app that helps with your study time. Another question about vents. We're going to skip that because I already talked about that. CVP monitoring. We talked about that last week. If you missed last week's broadcast, I'll just tell you that as far as hemodynamic monitoring goes as a whole for the transport environment, we're seeing it a lot less these days. Where you may see some hemodynamic monitoring show up in the transport environment would be things like just simple arterial monitoring for blood pressures. And primarily you'll see those when you're titrating medications that are rapidly hemodynamically or have a rapid effect on hemodynamics. And then things like balloon pumps, which you won't see too much in the flight environment, although more and more programs are starting to fly balloon pumps. Definitely in the ground transport, you'll see balloon pumps. So being able to monitor your arterial waveforms for the balloon pump, and primarily that's for timing. Now, that is essentially an arterial waveform. And if you want, you can go over and you can check out my Instagram page where I posted some pictures of the 4 primary waveforms that you need to know in order to, or you need to know very well for balloon pump transports. Let's see here. But if you just simply go over to, let's see, make sure, Instagram.com/FlightCrit. You can find my page. You can follow me there, and you can scroll down and you can see the 4 primary waveforms that you need to know. So early inflation, late inflation, early deflation, and late deflation. Those are the primary waveforms you need to be able to recognize associated with balloon pump monitoring. The other time you might see hemodynamic monitoring is going to be with Impellas. Now the Impella transports are starting to become more prominent, more programs are starting to transport Impellas, and more hospitals are starting to put in Impellas. So you'll see those with Impella transports. But CVP, there used to be a lot of emphasis on CVP monitoring for fluid resuscitation, and really what the latest literature is pointing out is that it can give you some indication of fluid responsiveness, but it's not as reliable as what once was believed. Now, that being said, if you have a patient throw a ultrasound probe on their IVC is where a CVP is monitored from, and their IVC is collapsing, with each contraction, then that they're under resuscitated. So I think ultrasound is going to take the place of CVP monitoring in the transport world. Yeah, well, I think just leave it there. I think the use of ultrasound is going to take over for a lot of these hemodynamic parameters that we used to use, with the exception of like these post-CABG patients, these post-heart patients who do have a SWAN in place, and they're closely monitoring their wedge pressures to make sure that the left ventricle is not being overloaded. Okay. Or that they're supporting the left ventricular left ventricle adequately. I think that's where you're going to see more of that's where you're going to see these hemodynamic parameters most of the time in the transport environment. Now, granted, in the ICU, it's a whole different story, and that's kind of not within the scope of what we do here. Let's see. What else? So this question here, drug infusion setups in critical care transports. Now, that's a very vague question, but I'm going to apply it to a patient that I just had this past week. And this is more of a learning environment or learning opportunity for everybody. Of course, that's what this is about. This was a steep learning curve for myself. Super sick pediatric patient. It was a post-arrest. And when we got this child, pH was in, it was 6.6. Okay. Base deficit was greater than minus 30. So profound metabolic acidosis. It was actually mixed acidosis with some respiratory component as well. But we were able to correct that fairly quickly. Lots of bicarb, calcium, because as we know, when you become acidotic, your potassium will bump. Okay, we know potassium is an acid as well. It's a weaker acid than CO2, and so the body tries to buffer that rising CO2 by pushing the CO2 into the cell, and in exchange for that, it kicks out potassium. So the potassium bumped from 4.4 to 7.2. T wave started to peak. QRS started to widen. So very complex patient. In this whole process, we wanted to hang an epi drip to support the blood pressure. And it used to be that epinephrine infusions were typically a mics per minute infusion. For whatever reason, every time our pumps go to biomed, they come back reset to mics per minute. So my partner and I pull up the pump, program it, because your pediatric infusions should always be set on a pump. You should never be gravity dripping a pediatric fluid or not fluid, but pediatric drug infusion. Should always be on a pump. And so the pump was, when we went into the library, found epi, it was mics per minute instead of mics per kilo per minute, which is now basically, where we should be dosing these patients. So your typical epi infusion for pediatrics is 0.1 to 1 mics per kilo per minute. Well, long story short, because of the complexity of this patient being very task overloaded, we were not able to troubleshoot this problem. Like, how do you take this this formula that's mics per minute and figure out, okay, how do I correct this so that we can dose them at mics per kilo per minute? So what I would say then to this question, drug infusion setups, is make sure that you really know your equipment. Okay. I am constantly playing with our equipment. And even with that, between myself and my partner, it became too much for us to really overcome that problem. So that I put that out there because, even though I come in here and I talk to you guys and try to help teach you, I'm constantly learning myself. And nobody is infallible. And so we need to recognize our weaknesses. And this was a weakness of mine that I recognized in that moment. And it's since been corrected. I have since gone over that scenario dozens of times and know that should I find myself in that situation again, the problem, I will know exactly how to manage that problem. So in that case, there was a very easy way to use a default drug option within the library to then manually program everything and still have it running on the pump in a safe parameter, which is kind of our main focus with these kiddos. So setting them up, make sure you know your drugs, make sure you know your dosing, look them up. All pediatric infusions should be cross-referenced with your partner and double-checked, and then run them on your pump. You really should never be pushing or manually gravity dripping any kind of pediatric infusion. With adults, pretty much the same way, although you can get away with certain medications like dopamine. You can get away with those just going by gravity. As far as pediatric fluid resuscitation, if you're going to run it on a syringe pump or you're going to run it on a pump, that's fine. But if you're having to bolus, the current recommendations are you should be able to deliver your adequate fluid boluses within 5 minutes. Your 20 mLs per kilo fluid bolus over 20 minutes, and that's repeated up to 3 times. Although you may need to, you could potentially, go 4 times or more. The key there is making sure that you're monitoring for fluid overload. So checking breath sounds, checking, if they stop, if the blood pressure is not responding after 3 rounds of 20 per kilo, then they're no longer fluid responsive and you need to be adding pressors. The best way to do that is with the push-pull method. And if you're not familiar with that, I will find a quick little article that I have, and I'll share it to the group so you can look that up. But it's basically putting a 3-way stopcock between your fluid and the patient, attaching a 60 cc syringe, calculating your fluid bolus, and turning it off to patient, drawing up your fluid into your 60 cc syringe, off to the fluid, push that in. There've been studies that look at meeting that fluid bolus goal, so 60 cc's per kilo times 3 within 5 minutes, and that has been the only way to reliably meet those fluid resuscitation goals in your pediatric population. Let's see here. Let me find this. And there's a number of articles out there. I'm looking at some right now, but if you just simply search pediatric fluid push-pull, you'll see a bunch of articles that pop up kind of talking about this. And I believe this is the one that I wanted to share. Yep. Okay, let me go ahead and pause this. I'll share this link. It's a YouTube video. Where's this from? Well, it doesn't matter where it's from, but definitely worth checking out. Okay, well, so we got about 10 minutes left in the broadcast. Last thing I wanted to do is go over a little bit with you, kind of what I've been working on lately for the EPICC Review Course. If you're not familiar with the EPICC Review Course, EPICC Review Course is a flight critical care transport review course to help people prepare for the FPC, CCPC, and CFRN exam. You can find out more information about it over at FlightCritAcademy.com. That's my academy page where I post not only the course, the EPICC Review course, but also another course that I wrote about preparing for the exam. So tips and tricks for preparing for the exam. I'll share those here, and you can kind of look at both of them. So FlightCrit Academy is the Academy site where you can find all the various courses that I have available. And then if you want to see specific information, details about the EPICC Review course, you can go to epiccreview.com, and that'll give you some additional information about the EPICC Review course. But so what's been going on this week is kind of finalizing some of the finalizing some of the last bit of lessons in the neonatal section. So let me go ahead and share some of this with you. I don't mind sharing this because I feel like, you know, that's why I do this. It gives you an opportunity to kind of see what is coming up, what is available if you are interested in the EPICC Review course. That way, you know what it is that you're purchasing. So the neonatal section, this is the essentials for paramedics in critical care. Although I've kind of debated whether or not I should change that to essentials for providers in critical care. I don't really know. The first thing I'll tell you as far as neonatal resuscitation goes is you really do need to take the neonatal resuscitation class. That's the best way for you to prepare for this exam when it, for the neonatal section. Kind of roll through here. We basically go over, the assessment of the neonatal patient, treatment of specific neonatal emergencies, understanding the relationship between the maternal and fetal circulation. I put this one in here. This is my little guy. This is my son Channing when he was just a couple days old. But I put this in here to illustrate the fact that, when he was born, he was only about 3 kilos. And the average fluid, our average blood volume for the pediatric patient is between 80 and 100 mLs per kilo. So this little guy, he's only got about 300 cc's of blood in his body. So when we're managing these neonatal patients, especially these trauma patients, we need to realize that they can bleed out very, very rapidly. And we can even cause hypovolemic shock in these kiddos if we are not careful, if we're drawing blood and we're just indiscriminately pulling 10 cc's of blood out for lab testing. In the PICU or in the ER, when they're drawing labs on these kiddos, they're usually drawing just the smallest amount because they just don't have a large volume of blood. There's this thing called the fetal hemoglobin. Okay, is different than our hemoglobin. Fetal hemoglobin has even greater affinity for oxygen than our standard hemoglobin. And so these kiddos, while they have less blood and they have less hemoglobin, their hemoglobin has a greater affinity. And so it causes this left shift. So if you remember that oxyhemoglobin dissociation curve, these kiddos will hold on to their oxygen much longer. They don't give it up to their tissue as well. That's why these kiddos, when they're first born, they're typically, they look a little blue, and it takes a little time for them to transition because their blood is used to holding on to that hemoglobin very tightly, or their hemoglobin is used to holding on to that oxygen very tightly. The other thing that will cause is their PaO2 will remain high when their O2 sats are low. So we talk about in neonatal resuscitation how you really need to make sure that you are titrating your resuscitation efforts based on, let me find this here, based on this time time curve. Okay, they say that a child, a neonate, right after they're born, their O2 sats should be in that 60 to 65 range, and it's only until 10 minutes after that they should be anywhere in the 90s. Okay, so what we don't want to be doing is hyperoxygenating these kiddos unless they are in arrest, okay, unless they are profoundly hypoxic, where their heart rate is less than 100. Those kiddos, they need oxygen, and you're probably going to just be, you're going to be turning your oxygen up, especially if you've already done, assisted their ventilation, you've given them blow by, you've done chest compressions, and now you're intubating them. As soon as you intubate them, they need to be on 100%. Okay. Until the point at which they are intubated, it is acceptable to leave your O2 saturations, your FiO2 lower. Okay, you're doing blow by, and you're trying to titrate to these minutes, or to these expected saturations based on this time. And this is pre-ductal SpO2. Okay, so what does that mean? Pre-ductal versus post-ductal. If you remember, there's the ductus arteriosus, right? Comes off of the aortic arch, and it bridges between the pulmonary artery and the aortic arch. Now, post-ductal, okay, after that ductus arteriosus, is considered the left hand and both lower extremities. And that's because anything after that ductus arteriosus, you're getting mixing of both arterial and venous blood. And so the O2 saturations will typically be lower. The right hand is your pre-ductal O2 saturation. Okay, so when you are doing a resuscitation, you want to have your pulse ox on that right hand so that you're getting pre-ductal, you're testing the O2 saturations before the ductus arteriosus, pre-ductal. Okay. Now, if you have a second monitor, you can throw it on the toe or the left hand, and you can get the pre and post ductal O2 sats. And by measuring the difference between the pre-ductus and post-ductal O2 sats, you can that will help you determine if you have some kind of a congenital, cyanotic congenital heart defect. Okay, because there will be this persistent mixing, and you will have lower. You'll have a greater difference between the pre and post ductal O2 sats. Okay, and we'll talk more about that within the course, talking about cyanotic versus acyanotic heart lesions and how do you manage these patients. But the big thing I'll tell you is, if you identify a cyanotic heart defect, these kiddos, you have to keep their O2 sats low, and you need to keep that ductus arteriosus open, right, with prostaglandins, okay, because they are dependent on that ductus arteriosus for blood flow to their systemic circulation. And so if that ductus arteriosus closes, they can either have a significant reduction in their cardiac output and their oxygenation. Now, high concentration of oxygen induces the ductus to, or will stimulate the ductus to close, and other chemical mediators in the body that are released once the lungs dilate and they start receiving oxygen will also cause that ductus arteriosus to close. And prostaglandin is the medication that's given to keep that ductus arteriosus open. We got a couple more minutes here. Let me pop back over to the group and see if there's any questions. Kind of scroll down here. I don't see anything. If you have any questions right now, you can go ahead and just put them in the comment section before we wrap this up. What else do I want to go over here just real quick? See if there's anything. We'll talk about post-resuscitation care. In the course, we will also briefly go over the steps to neonatal resuscitation. We already talked about time-based resuscitation. When you start compressions, right? We know about less than 100, you're starting compressions. We're going to talk about things like fetal blood loss, these various emergencies of that we might experience with kiddos. Necrotizing enterocolitis, this is one of the greatest risk factors for premature kiddos. Can be very deadly very quickly. We're going to talk about like intestinal atresia, and you'll hear the term double bubble, which is a sign that you'll see on the CT or abdominal films. And there's basically two bubbles that show up in the abdomen. One of them is is here, right? It's the abdomen. And then there is a twisting of the intestines, typically right at the junction between the stomach and the small intestines, and you'll get a bubble here as well. The other key finding for intestinal atresia on the exam is this green bilious emesis. Okay, so you have this emesis that's green that is very indicative of this intestinal atresia. Talk about coronal atresia and how to identify these. Coronal atresia is this bony prominence at the back of the nasal pharynx, right? And so we know that kiddos are obligate nose breathers. And so if you have this kiddo who is hypoxic when they're nursing, and then they start to cry and their hypoxia resolves, that could be an indication of coronal atresia, because they can't breathe when they're eating. Now, kiddos are early, neonates, or not neonates, but newborns have that ability to eat and breathe at the same time. But they have this poor, initially they have this poor suck breathe coordination. Now, as we get older, right, we're not able to swallow and breathe at the same time. And so that kind of goes away. But early on, these kiddos, they can eat and they can breathe so long as their nose is not obstructed. So, boogers in their nose or these coronal atresias can cause all kinds of problems. So if you had that kiddo who's trying to nurse, mom keeps saying, he's not eating well, and you, through your history taking, you find out that, he turns blue and, O2 sats maybe drop while he's feeding, or he just can't feed. It may be that you have a problem with coronal atresia and the kid just can't breathe while he's trying to eat. These are typically repaired, through surgery. Gastroschisis we'll talk about. We are going to go over all your cyanotic versus acyanotic heart lesions. And just because it's an acyanotic lesion does not mean it's not critical. We'll talk about some of the differences there. We'll talk about some of the signs that you'll see, the boot sign, egg sign, snowman sign, on how to identify what the, if you saw these on a film, what the cardiac defect might be. All right, so that's about an hour. I want to thank everybody who's tuned in to watch the broadcast. And if you have questions, keep them coming. This will be available for a while here, so you can watch the replay. If you are tuning in to the replay, again, you can leave your comments. And this is my weekly broadcast, so you'll see me again post the office hours every Tuesday from 9 a.m. to 10 a.m. If you have questions, you can send them to me in the group, or you can email me, Sean@FlightCrit.com. And let's see, what else? Yeah, I sure hope you find this useful. If there's anything that you'd like to see me cover, please just let me know. I will go over a little bit more of neonatal section of the EPICC Review course next week, and then also pediatrics. After that, there is endocrine emergencies. That's part of the general medical, and then toxin environmental, and the course will be done. And then we'll get back to the podcast. But hope you've liked this. If you want to find out more again about the EPICC Review course, epiccreview.com, or you can go over to FlightCrit.com and click on Academy at the top of the page, and that will take you over to the Academy page where you can find out more about the EPICC Review course and all the other courses that I have listed over there to help you be successful. Remember, this is all about you. Excellence through collaboration is my motto. I feel like that's the only way that we can really excel and take care of our patients as best as possible. And like I said, if you have questions, leave them below. Other than that, until next time, thanks so much. Fly safe, live well, and we'll catch you later. Bye for now.